Sorry, thank you, Maureen. It was a little too quick on the unmuting part. So before we get started, I just wanted to go back over a few things that Maureen has just talked about that are important for you to think about after you've gone through this presentation. The most important thing that we just released at National is the Standards of Practice of Case Management 2022. And it's a very important document that once you finish this particular program, you're going to want to go back and reflect on, because it's important to look at what are our professional responsibilities as professional case managers. And there's many new avenues in this booklet. One of the first I would like to just point out is there's an area that defines distinctly now professional responsibilities, our legal responsibilities as case managers, ethics, our role as advocates, our cultural competence, our ability to integrate with health information technology. And one of the large things that this also addresses is healthcare disparities. It's very important to understand the new standards of practice when you understand the workplace violence webinar that we're about to present. So as you can see, there's a little picture on the side. And when we're talking about workplace violence, sometimes this is how a case manager feels. They feel a little bit like they want to hide under the table or pull themselves back when this type of behavior is going on. And one of the things that I've noted when speaking with other case managers is a lot often feel at first when they see this topic, it doesn't happen to them. And I think what I'm going to show you over the next 5 or 10 minutes is that it does happen to you, and it does actually happen to all of us at all continuums of care. So first, a disclaimer. Both Amy and myself have no financial reimbursement or represent any company associated with workplace violence. We will be mentioning some corporations that provide analysis and training for workplace violence, but they're used as examples and models that can be out there. But there are many examples of models for how to be able to set up a workplace violence program, either at your workplace or to be able to have even your own personal way of defending yourself from workplace violence. The goals of the session are to identify workplace violence, to help you understand what it is and how it can occur within an organization. It's to identify the process improvement strategies that can keep healthcare workers safe. It's to show knowledge of the new JCAHO standards for creating a culture of safety that are coming out this year, and it will soon to be developed for the other levels of care. And that's important for you to understand. We're introducing in this session the JCAHO standards for acute care hospitals, LTACs, and rehab hospitals. But if you follow the JCAHO standards and are preparing yourself for your organization to become JCAHO accredited, you will see that in the environments of care, they're starting to build these same cultures of safety and focus on workplace violence for behavioral health models and also for community-based healthcare programs. We won't be presenting that tonight, but they are being developed by JCAHO. And if you go to the JCAHO website, you can actually see some of the beginnings of their new environment of care programs. It's also to identify how this workplace violence impacts you as a healthcare worker and learn what you can do to protect yourself and create a personal culture of safety. The first part of the program will be focused on organizational development of what needs to change in order to create a culture of safety. And the second part of the program, which Amy designed, it really looks at the personal culture of safety. How do you protect oneself? That can be used not only in an acute hospital environment, but also can be used in your own personal, professional work with patients and families. And finally, the last is the knowledge of legislation that is being implemented both at the state in Massachusetts and at the national level of government to help us be able to protect ourselves from workplace violence. And you'll see legislation that's looking at developing culture of safety, as well as actual legislation that's beginning to look at criminal intent for people that are perpetrators of workplace violence. So let's talk about something near and dear. I'd like people to understand how it can happen to you. At our conference in Orlando, at the CMSA conference that was about 2 weeks ago, 2 significant incidents of workplace violence occurred. And I'd like to go over that so that you can see how it can happen to anyone. Colleen Morley, who's the new incoming president, shared with me a recent article that she'll be publishing in the next month in case management brief that will be available to all members of our society. But I would like to show you how this can impact even any of us at any level of the continuum of care. On June 1st of this year, a disgruntled patient shot his surgeon. He shot another doctor, a receptionist, and a nurse at St. Francis Hospital in Tulsa, Oklahoma, before killing himself. And if you notice, that was only about 3 weeks ago when that happened, began in the beginning of our case management conference. One day into the conference, another man was charged with attempted murder after stabbing a doctor and 2 nurses in an emergency room in Encino Hospital in California. A nurse was kicked and bitten in South Dakota. A medical student from Thailand was called China virus by a patient and a family, and they were kicked and bruised in the process of trying to provide care at their local hospital. Legislation in the last few months has been introduced by Madeline Dean, who's a Democrat from Pennsylvania, and Larry Burshan, who's a Republican from Indiana. And their bill is called Safety from Violence for Healthcare Employees. It's part of the new Safety Act. And if you Google that, you can get more detail. It is supported right now by the Case Management Society of America, by the American Hospital Association, by the American College of Emergency Physicians, and many other healthcare organizations. And this is to bring not just awareness to the workplace violence situation, but to understand that there should be criminal intent when this occurs and that they will be persecuted by the healthcare facilities in which this occurs. It's important to understand that the legislation is escalating as the events are becoming more difficult. In my own workplace environment, just last night, I was dealing with a patient who became increasingly agitated. And as he was becoming increasingly agitated and we were preparing to help him calm down and relax before he went for a procedure and to go into an MRI, which we knew would make him nervous, the patient, before we could give him medication, reached out and actually slugged one of the nurses and sent her to the emergency room to be looked at for what to determine whether or not her jaw had actually been broken. So when we think it can't happen to us, the reality is it can happen to us, and it can happen in a very short moment of time and become out of control.
Jenny?
Yes?
Sorry to interrupt. I by accident stopped your video. Could you start it again?
Oh, my video?
Yes, I'm sorry.
Oh, yes. Sorry. Nope, that's okay. I have it. Okay, so just to give you another instance when we say it can't happen to us, well, as a professional case manager, it can happen to us. And I can give you 2 incidents where this year alone, it happened to me. I was called down on a weekend to break up a fight between families who were fighting in our lobby about whether or not they had the right to go in first. We were dealing with the COVID precautions, and I actually, for the first time in my life, had to come down to the lobby and sit down between 2 family members and work out the dispute and ask them to come up with their own solution for who could come in first. But they were literally to the point where they were yelling and screaming at each other. They weren't mad about the hospital in any way. They were just frustrated that one person had gotten to the hospital first and one had gotten second, and it erupted in a fight. So I know that we often say it hasn't happened to us, but the truth is, I think if we all think about it, we've had situations where this has happened to us. So important to understand recognizing workplace violence. At least 1 in 4 nurses, and I would include 1 in 4 nurses or case managers, are assaulted on the job. This is why workplace violence continues to be one of the top priorities for creating a safe, healing environment for patients, families, and healthcare workers. In April of 2021, the House passed a workplace violence prevention bill for healthcare workers and social workers. There were thousands of people that marched on Washington to participate in this grassroots campaign called rnaction.org. It had successful bipartisan support and the bill passed. This bill directs the Department of Labor to develop safety standards that will require employers, in healthcare and social settings to implement plans to protect employees from workplace violence. Next slide. So how did this happen? What emerged to create this culture for violence? Mahatma Gandhi, the famous philosopher, is quoted as saying, "Be the change you wish to see in the world." This couldn't be a truer statement when it comes to addressing workplace violence. Change is needed in our culture right now for patients and family interventions with staff, for staff-to-staff interventions, and management to staff communications. So we have to look at why did this occur and why does this continue to thrive? When in beginning of COVID, I think we all are clear and we could all recognize that the healthcare profession was really provided as heroes. And we were going to be the ones that were out there to help fight the COVID, and we were resilient and we had grace and we were being able to maintain an environment where we were the healing power. What happened is COVID then became a situation where it occurred over a period of 2.5, almost 3 years now. And we're looking at chronic stress and crisis management, and any stress over time causes continued breakdown. So the question is, did we have workplace violence before COVID? Yes, we did. And it was definitely in all of our environments, the continuum of care. However, as we moved throughout COVID, increased stress, increased anger, increased frustration regarding COVID-19 added to people's inability to communicate with families or loved ones while they were either in the hospital or in any healthcare setting, and communication broke down more with healthcare workers. I think if we think about all the different ways that we've tried to maintain healthy cultures and healthy environments over time, it's very difficult. We're dealing with many patients who are using telehealth, and they're using computer systems and Facebook, and they're using laptops to be able to communicate, or telephones, and they're not able to see either their loved ones or some of the healthcare providers actually in person. This over time, although it continued to allow us to have communication, also created quite a bit of stress and difficulty in terms of being able to function. Then add to it the actual rules and regulations of COVID-19. You can only have 1 visitor, only 2 visitors. Then if it's a hospice case, you could have maybe 2 visitors every 24 hours. There were a different set of rules and regulations every day, and that became very challenging, not just for the healthcare workers and the staff-to-staff communication, but it became challenging for patients and families to understand. So when we look at workplace violence, although it had stayed on a steady stream over time, it increased significantly during COVID. So when we look at it, any environment, of course, under stress will begin to break down according to, if you look at the Pulse's nurses survey, the ANA has been following the COVID-19 pandemic for quite a while, and they've been looking at this particular issue of workplace violence and all the issues surrounding safety for nurses, as well as social workers. 47% of nurses report having experienced during COVID-19 an experience of workplace violence that is compounded by staffing shortages and the ability to recuperate from these staffing shortages becomes more challenging. The pandemic from 2019 to current day created the perfect melting pot or scenario for this issue, not only to emerge, but to really grow. And that's why legislation and cultural changes have become so important. The ANA, our American Nurse Association, has really taken the lead on workplace violence for legislation, standards of care, and to support and change the workplace and promote a new culture of safety. If you go to the ANA national website, they have an entire area on workplace violence. Nice overview of the legislation and the standards of care that they're recommending for all levels of the continuum of care. So who's at greatest risk for this workplace violence? One of the things I think it's important to note is who's at greatest risk. Well, nurses and social workers are, because we're the ones that are on the floor dealing with the patients, and we're the face that the family members see when they come in. But one thing I think is important to note is case managers in particular are at risk. And I would like to talk a little bit about why. We are the advocate, the negotiator, the educator. We assist patients and families to navigate through the red tape. The environment during COVID-19 has become quicker and faster. The rules have changed every day. And the ability to be able to navigate that system has become even more challenging, bringing with it to patients and families increased agitation. And we've had to now act not only as advocates and negotiators, but we've also had to really wear our hat as psychotherapists, because we've had to calm down people and decrease anxiety on a daily basis. The new CMS waivers, although meant to be helpful and have been extremely helpful with helping us navigate and transition through the continuum of care, not even needing to maintain a 3-day stay to get into nursing home, has been extremely helpful, but yet at the same time caused a lot of friction because the old rules no longer applied. And with the new rules, patients and family members had to learn to grasp all this change, and trusting the case manager became more challenging. As case managers, we're really the key people who provide change within the healthcare team. So we often are placed in a position where we're dealing with the anger and the frustration that patients have, as well as helping them to problem solve. And when those two things come together, we have to develop new skills, not just how to case management, but also how to calm down and maintain people in an anxious state so that they actually can take the time to listen and hear and be able to work with us effectively to be able to do what's best for the patient. So what's the definition of workplace violence? Next slide. This is important to understand. Workplace violence can take forms through verbal and physical. I think a lot of us think it's just physical, but it can be verbal interactions with a patient, family member, staff, or administration. It can be a physical abuse, such as a patient or family member hitting. It can be bullying, harassment, exclusion, intimidation. It can be targeted and perpetrated by a range of individuals. And that's what's really important. When we talk about workplace violence, it is not just a patient or family at a staff member. It can also be staff to staff, and it can be administration to staff. And we've all felt these different changing levels of tension that can happen or breakdown in communication throughout COVID. And these effects can impact professional and physical consequences for all members of the healthcare team. And that's what's important to understand. When we're talking about workplace violence, we're not just talking about the nurse, the case manager, or the social worker. We can be talking about any member of the healthcare team. And as we start to talk about how to combat workplace violence, it's important to understand that any member of the healthcare team could be the one that is the target of workplace violence. Now, the National Institute of Occupational Health and Safety defines worker to worker, personal relationship, a customer to client, and the actual criminal intent of violence in the workplace. And it's important to understand that there are different levels. It can be your staff to staff, as you're going throughout your everyday interventions in a hospital or community environment. It can be a personal relationship that you have at home. It can be customer to patient or client, whatever terminology we're using, or it can be criminal intent as categories of violence in the workplace, such as the person coming in and shooting their surgeon. And what are the stages of workplace violence? Next slide. Important to recognize, what are these stages? Level 1, when someone is acting in a violent manner, whether it's physical or verbal, you have to start to recognize the warning signs of violence. It's important to see them coming at you, that there's been a change in the temperament of the culture and environment. Now, when I look at my own workplace, one of the things that we have now as we're preparing our environments become more of a culture of safety is that when you walk into the lobby, when you walk into the elevator, when you walk up to the stairs, when you walk onto a unit, there are signs that remind us that this is a culture of safety, that all employees work here to provide a healthy environment for the patient, for the family, and to have healthy, safe interactions among staff, team members, and the patient and the family. But at the same time, we reserve the right, if that culture or environment were to change, that we would ask a patient or family to leave the environment. We might bring security in that we also reserve the right to bring in outside law enforcement if a culture or environment changed too drastically. And level 2, understanding is to see that there's a slightly more violent nature or tone to what's happening. Maybe you're seeing the person start to escalate and they're raising their voice while they're talking to you, and they're in your face and they've now invaded your space. And level 3 aggresses more to the not only in your space and raising your volume, but maybe seeing the person start to smash down their hand, or they're aggressively, if it's a patient, getting out of the bed and starting to walk towards you. But level 3 would be seeing an actual physical movement towards violence. And the last one is that many workplaces have initiated programs and protocols to protect their workers, as the Occupational Health Act of 1970 stated that employees must provide an environment in which employees are free of harm or harmful conditions. Next slide. So once we've recognized what the problem is, or we've recognized that there's an escalating situation, how do we begin to fix the problem? Well, we fix the problem, first of all, by, number one, recognizing that these issues exist in a healthcare environment and will require a collaborative approach and input from all members of the team at all levels of the healthcare, so that when violence occurs, it's not just aimed at the professional case manager. It could be the nurse, it could be the aide, it could be the healthcare PT rehab team, it could be the doctors, it could be any members of the team, but we all are part of the healthcare environment that could have some type of violence aimed at them. So it's important to recognize that. I think the thing that we also need to do in fixing the problem is we need to recognize it occurs. And one thing that I feel strongly I need to point out at this point, particularly with nurses, we have a tendency at times when we're talking about workplace violence, and this is something I'm very sad to say because I know I've done this myself, we have a tendency to sometimes brush it off and say it's just a part of the changing environment. And somehow in our heads, we're thinking we deserve this. And it's very, very, very important as we're working at fixing the problem that we recognize when something has now gone beyond what should be a normal, healthy, professional relationship of any healthcare worker working with the patient. Once we've seen that it's gone past a certain point, we need to recognize there's a level of violence in that situation, and it's time to start to institute what we've learned. And we'll be talking about that in a minute. But I think it's important to recognize that there's a tendency with healthcare workers, particularly nurses, but all healthcare workers, to minimize violence as though it's a normal part of our environment now. And I'm here to tell you it's not, and it needs to change. So finding a solution, and this is where we're going to get into the nitty-gritty of how do we fix this and change this. Over the last 2 years, violence against healthcare workers, verbally and physically, by patient and or family, has increased. And it's become of particular interest, and this is really important to the Joint Commission for the Accreditation of Healthcare Organizations, JCAHO. In fact, it's become so important to JCAHO that as of January 1st of this year, JCAHO instituted new environments of care for acute care hospitals, LTACs, and acute rehab hospitals. And this is implementing a new workplace violence mandate as of January 2022. And the Department of Labor, local nursing, and social work organizations are supporting this change that JCAHO is providing. So next slide. JCAHO's beginning with LTACs, hospitals, and acute care rehabs. However, on their website, they're also beginning to show that they're moving and evolving this type of program and thinking into community-based behavioral health, and soon you'll see it in all levels of the continuum of care, because we all know that workplace violence, if we really pay attention to what's happening in the media, can happen anywhere at any point in time. So how do we combat the solution? What JCAHO is proposing is a few things, and I want to go over this because it's very, very important that we understand this. It's a very comprehensive approach to change that we've not done before. In presenting this particular webinar, we presented it first as a poster at the national conference. And one of the things I learned quite a bit from many people working in different hospital environments is, yes, we all had a recognition of workplace violence. We all had behavioral codes on our little badges that would let us know if somebody had now become out of control or they were agitated. And we all had some type of crisis prevention, intervention training. However, what we didn't have was a formalized approach on how to deal with this. And this is what JCAHO is asking us to do, not just recognize it, but to understand that we need to have a culture change, and we need everybody to be thinking the same way about the culture change. So the first thing that has to happen in any hospital, community, or behavioral health environment is we need to define workplace violence so that we all understand that workplace violence can be patient to and family to staff, staff to staff, administration to staff. We need to understand that it can happen at all levels of continuum. The other thing we need to do is we need to have leadership buy-in at whatever level of the continuum of care we are. We need the leadership to understand and have oversight of the workplace violence program. And they need to implement it not just at the administration leadership level, but also at human resources. There need to be safe places for people to be able to report, go to, and get the help that they need in order to be able to combat this situation. Once we've defined workplace violence within our system, we then need to talk about the leadership oversight. So when we're creating a team to work at this and develop the protocols and systems that need to be in place, we need a member from all levels within our administration, as well as a doctor, a nurse, a case manager. We need somebody that represents rehab. We need somebody that represents social work. We need somebody that represents all levels within our team. That team then needs to look at worksite analysis, and this is the most important thing. It's very, very important that whatever you present with regards to workplace violence prevention programs, you need to analyze the type of violence that you have. Before you can create a culture of safety, you could take a look at patient and family to staff, or you could look at staff to staff, or you could look at administration to staff. But if you haven't isolated the type of analysis of the type of violence that happens in your place, you could miss the boat on how you develop a culture of safety. If 80% of your issues occur from patient and family to staff, then you need a large part of your program to be focused on that, but there still needs to be a mechanism for the other two things to occur. So it's important to analyze and understand the type of violence. It's important to have a reporting structure for any time something happens. It is reported immediately to human resources. They create a system for data collection, and you're able to, after you've implemented a program, you're able to go back and analyze and see, once you've looked at the data and you've implemented a program, you need to be able to then record whether or not you've actually been able to stop and change the environment and create a culture of safety. So you implement reporting systems, data collection, analysis. And the key is also, just like you do in a code, you have a post-code conversation about what went right and what went wrong. You must always have with workplace violence a conversation about what went right and what went wrong. Take the incident I talked to you about, the patient becoming agitated and they slugged the nurse yesterday. We had a post-incident strategy conversation today. We reported it and we had a conversation about what went wrong, what we could do differently in the future, and how we can avoid the incident. We talked to the people involved in it. We talked to the people on the unit, and we talked about what we could implement differently for that patient so that they can feel safe in the environment and the staff can feel safe working with that patient. And then the last thing that's important, if you don't have, is you must have, before you implement any new program for workplace violence, you must have some type of CPI training. Now, it doesn't need to just be CPI. CPI is one of the avenues that exists out there. It just tends to be a crisis prevention intervention training program. It is an evidence-based program that teaches you first de-escalation strategies that are all verbal on how to recognize violence, see that it's happening, and how to begin to de-escalate the patient. And then the second part is about how to take down a patient if you needed to, in order to make them feel safe and put them into an environment where they can maintain safety. So JCAHO's elements that are evolving this year, in the next slide, for the continuum of care, as we've talked about before, there's an element of performance for leadership that they must meet in order to understand workplace violence and be able to put in place all the support needed for staff to perform a safe new change in culture. There's the elements of performance human resources that human resources would put in place for how to talk to people, record the data, and be able to help provide analysis for staff so they can fine-tune their culture of safety. There's elements of performance of environment of care. There's a focus on creating the actual culture of safety. And in the future, for the next couple of years, they'll be developing emergency room culture of safety, community-based, and behavioral health centers to look at creating similar programs for culture of safety. So JCAHO's rolling out first, as we've said, to acute cares, LTACs, and to acute rehabilitation hospitals. So we're going to go to the next slide so that you can understand what is CPI and why use CPI. Well, CPI, crisis intervention training, is evidence-based protocol that can be used for workplace violence in any levels of the continuum of care or in a hospital environment. But it also is trauma-informed care for healthcare professionals. They've been developing a way of not just implementing workplace violence, but how to help healthcare professionals be able to manage the trauma that they experience when working with violent situations. So why we use CPI? The incidence of violence against healthcare workers are documented in CPI analysis currently as the following: 85% of all assaults in U.S. hospitals are workplace violence type 2, patient on staff or visitor on staff assaults, according to the 2020 Healthcare Crime Survey. 73% of the non-fatal occupational health tracked by U.S. Bureau of Labor occurred in healthcare and social assistance. So over a 12-month period, 21% of registered nurses and nursing students reported being physically assaulted. and 50% verbally abused. Over a 7-day period, 12% of emergency department nurses experience physical violence and 59% experience verbal abuse. In 1 year, 13% of the employees in the VA reported being assaulted. So as you can see, the percentages that we're starting to calculate are pretty high. And when you do CPI training, they've recorded this data, and they've been working with all levels of the continuum of healthcare to try to provide people with safe strategies to create a culture of safety. Next slide. So what comes first with CPI training? It's de-escalation skills. And I often say 85% of the work we do can be modified with de-escalation skills. If you know how to de-escalate first when you're doing CPI training, and I'll speak from this because this is what I'm trained in. When you do de-escalation skills, you're trained to go to any challenging code, behavioral code for a patient. One person is the team leader. Their job is to begin the verbal conversation and de-escalate the client or the family or the staff to staff. So one person comes as a team leader, but you're trained as a team of about 4 or 5 to quickly notice if that person were to not be able to engage with the client or the family, then we quickly trade off and another person takes over. Okay. So the analysis of violence, incidents, and surveillance are important to target the best intervention for healthcare facilities. We're going to go to the next slide. So what's CPI? CPI is a nonviolent crisis intervention. It is nonviolent. There is no physical attack involved in this. It provides you with training. Usually it begins with an 8-hour training, 4 hours thereafter for any type of ongoing mandatory training. And you are expected to be retrained and certified every year. So it provides in the beginning prevention and verbal de-escalation techniques, disengagement techniques, continuing ed credits, trauma-enforced training, risk assessment framework, and physical intervention. Next slide. And crisis prevention training is an evidence-based protocol. It's been shown to work, and it works very successfully in many environments. And as we go forward, I'd like to mention the workplace violence legislation that we have that's beginning to support workplace violence and try to help us be able to minimize this. In Massachusetts, an act requiring healthcare employers to develop and implement programs to prevent workplace violence. There's also HD 1893, an act requiring healthcare facilities to develop and implement programs to prevent workplace violence. And there's an act requiring healthcare employees to develop and implement programs to prevent workplace violence. An act requiring healthcare facilities to develop and implement programs to prevent workplace violence. As you can see, these are both sponsored both by the House and also the Senate. All of these bills were initiated by the American Nurse Association. They are also supported by the Mass Hospital Association and by the CMSNE Public Policy. And these are mostly, as we mentioned earlier, the Safety Act is a national, these are all local Massachusetts-based legislation that is being looked at this year by our Mass State House. And the next slide. And I'm just going to stop here for a minute. I'm going to pass over to Amy Chartier, who's going to start looking at the workplace violence with regards to how it's experienced from a personal perspective as a professional case manager. And Amy, I'll be passing that to you right now. Are you on?
Yes.
Okay.
Hi. I'm going to be talking about the reality of the current situation. So Jenny talked a little bit about the formality of the situation, and I'm going to focus on an article that was recently actually published this year by Suzanne Powell and Ellen Fink-Samnick, and it was called Workplace Violence and Bullying, You Can Survive. So this article focuses more on how you as an individual and as a person can respond to this. Even though, change can take a while, and changing to a culture of safety involves everyone, you as an individual can at least begin to change how you respond to it. So the article opened up with looking at some studies that were done on healthcare employees in Arizona, and all of this information is current as of 2022. So as you can see, the statistics were unbelievably high. 68% of staff reported that they are concerned for their safety. 57% of staff reported experiencing emotional distress related to incidents over the past 12 months. And 74% of staff with patient to visitor contact experienced misconduct by a patient, a family member, or a visitor in the previous 12 months. 41% of those staff experienced 6 or more incidents at a time. So as you can see, it's, again, as Jenny mentioned, it's not just nursing, it's the staff in the hospital as a whole, any healthcare staff. Also, when looking at other studies, I did see that the numbers during the pandemic have certainly increased by large amounts of healthcare workers that are experiencing workplace violence. Next slide. So the article also talked about other areas where this is happening. So it's not just a study done in Arizona where it's happening, but it's also a global problem. Recognizes that workplace violence doesn't just happen here in the United States, it happens across Europe. It speaks all languages and is felt by any and all healthcare staff throughout the world. So 79.3 million workers are affected by workplace bullying. And this was a number taken globally. People in non-leadership roles experience workplace bullying that is double the rate of those in managerial positions. And that's just to emphasize, to back up, Jenny had also mentioned that about, nurses being the mainstay and being on the front line, and that's who it's mostly happening to. Next slide. So then we look at, well, what can be done about this? So we know that change is a work in progress. And like I had mentioned, especially when you're looking at it from a global perspective, it's can be a very large and overwhelming problem to start to break down. But we can change immediately how we as individuals and personally respond to workplace violence. So in the article by Suzanne Powell and Ellen Fink-Samnick, they talked about a few steps and a few tools that we can use to recognize it and then also to help stop it. So for example, some of the tools were ensuring that all complaints go through HR for recording purposes. So it's really important to have it all documented, written down on paper, and going through the appropriate channels. Also ensuring that every encounter of workplace violence is documented. And interestingly enough, if the environment isn't changing, then you as an individual change. You find a new work environment. So I think that was the one that stood out for me the most, is that it's that imperative to your mental health and your personal well-being, that if the environment is, becoming too much and it's not changing, then it's worth it enough that you need to find somewhere else to work. And that's how serious this matter is. Next slide. So lessons learned in the article. The two authors spoke about how abrupt communication has become the norm. So, coming in, being very short and very direct with people has become something that we've all learned to, use as communication. But they're saying that it shouldn't be the norm. It should be something that we don't hardly use at all, instead of something that we use all the time to interact with other people. They also mentioned something called intellectual humility, and making sure that people are aware of those that have a low intellectual humility. And intellectual humility is defined as a person who believes that they're right all the time. And interestingly enough, 82% of people think that they're right all the time. So I also thought that was a very interesting statistic, and maybe it rings true for some of us. So people with low intellectual humility are unable to accept that someone else may be right, and they're unable to include all opinions and all thoughts of other people. And they're not able to look at them all equally because they believe that they're always right. And then if you recognize somebody that has that low intellectual humility, it's really important to be open to others during discussions, to ask questions, and allow others to state their thoughts. Especially if you recognize that you are someone with low intellectual humility. Those are a few steps that you can start to take to be more open to others' opinions. Next slide. And the last thing that Powell and Fink-Samnick talked about were mantras to repeat to yourself, to say every day or say every other day, however it works for you, but to talk about these 6 mantras that can help you have no tolerance for workplace violence. So the mantras begin: we deserve respect. We deserve to have our knowledge and expertise valued. We deserve to feel safe. We deserve to not feel trapped in a toxic workplace. We deserve to have confidence that all are accountable for their actions. And we deserve to be able to confront workplace bullying without fear of retribution. All of those are really important, even if it's just one of them. They're all super important. And again, how many of us can reflect back in our nursing careers or social work careers and think, you know, how many times have we been mistreated and bullied and labeled it as it's part of the profession? And, you know, some truth to mantras that once, you know, if you repeat them often, they can oftentimes become your truth, which is pretty interesting and definitely something worth trying, especially when it comes to workplace violence. Next slide. And that ends our presentation. So if anyone has any questions, you can either put it in the chat. I believe, is that?
I think we have question and answers too. So do you want me to look at the question and answers?
Sure.
Okay, or do you want to say them, Maureen?
No, Jenny, why don't you guys, because you could handle them better.
Okay. Okay, so the first one is Marion Gerard Spino. Any data on how many healthcare providers currently press charges post-assault? Actually, I can give you there is not actually data because it's so new, but we will have that in the next year, I will guarantee you, because that is a part of the JCAHO standards. And one of the things for that new legislation that we were talking about that actually Colleen Morley had told me about, which is the safety from violence for healthcare employees, it would criminalize assault or intimidation of hospital employees and provide legal penalties. And in that bill, they will be recording the assaults and the issues that are occurring nationally once that gets passed. But I know that, you know, if we even look at what happened in the last month, there was 2 cases in the last month against healthcare workers. I don't know if that answers your question or not. And the other thing you wanted to know, the citation for Ellen's article that she's referring to, yes, it's actually in the next couple slides. Amy took care of that. It's professional case manager, which is the professional case management journal that we have that really focuses more on, it's not just an opinion type of journal. It really is a journal that looks at statistics, data, and research. And I know one of the things that Paul and Ellen Fink-Samnick are working on is actual research now, because they're so concerned about the workplace violence issue. It's really becoming a very hot topic. Particularly when you can see that so many different organizations like the ANA, Mass Hospital, the hospital associations, and also organization of nurse leaders are really getting involved in wanting to help create the cultures of safety and focus in on how to help change the environment. And I think Amy's point being, in that last section where we looked at ourselves, it's very, very, very important on a personal note to have those mantras. I did read through Amy's slides as I was reading that, and I practiced it this week. And it makes a big difference to tell yourself to not see this as the norm. And I have to tell you, to be honest, in looking at this issue, I didn't realize how often I saw it as the norm. And it's something I'm trying to actively work at changing. Am I hearing that providers are terminating care for assaultive patients? Yes, yeah. I am hearing that. Yes. I think that people are starting to understand it's okay to be able to have limits. And in creating a culture of safety, one has to know where the boundaries are. And I think one of the things that I found for myself in dealing with COVID, it was very easy to be stuck in the COVID environment and not see things as normal. And it's important. I know on a personal note, I'm trying to work very hard towards getting myself back to a norm and a balance. And Amy, I don't know how do you feel about it, but I know you also work in acute care.
Yeah. So, I mean, I feel the same way. I did do the mantras myself this week. And I think it really helps to help you as a person recognize that it's not the norm. Those mantras really help it stand out in your mind that, no, I don't deserve this. I'm here for a purpose and I'm here for a good reason. And I care about patients. And, just kind of repeating that to yourself really helps build your strength for having a no tolerance attitude towards it. And it really helps get that routine, that habit thought of, oh, it's just part of the job. It's just part of the job. And I mean, I've even said that myself, even around family, and people ask about, tempers and things like that with patients. And it's always been, people are under stress, people are sick, and it's not okay. It's not okay.
And Amy, I'm reading, Rose is asking a question. She's noting that many case managers staff do not want to report toxic workplace situations due to history of no changes. And these behaviors continue to happen. And I think you should take that question.
Yes. So I think that going forward, especially, with COVID, I think that these changes are going to start happening. And I think when a bigger organization, fortunately and unfortunately, like JCAHO, when they start to stand behind things, it gets taken more seriously. And then I think also spreading the word and educating other case managers like we're doing now in these webinars is really important, because once you know better, you do better. And in this case, it's very true. And then, once we get the word out and talk about it at work, it becomes a topic that comes up now and again, once you plant that seed in other people's heads.
I think that's a good way of putting it. And I think it's unfortunate that sometimes you have to have the power of something like JCAHO or the occupational health, but the truth is they've opened a window with power in it, and it's really going to be able to help us move forward and create change. I'm amazed in the last 6 months how much has happened around this particular topic, and it needs to keep happening. And even when I walk into my own place and I see the signs of the type of environment we want to have created that are there, it makes me feel better just to read the sign. I feel like I have support that I never had before, and it feels like it's okay to start to talk about it.
Right, and completely take advantage of the fact that they're bringing this up as one of their 2022, things to work on, things to change. And I am hearing it at work myself from patients. I'm not allowed to go there anymore. They, had the police involved with me over there, and I can't go there. And right. So it's starting to take effect. It's slowly working.
And I'll tell you, nothing made me feel better than when the incident with the nurse happened yesterday, just to see the staff come to the nurse's station in kind of a private way and talk about, what didn't work, what could have worked better, how we could change things, how we could take care of ourselves better. And it was great. It was great, to really see that emotion. It was kind of nice. It was definitely nice.
Yeah.
And I hope to be a part of more of that.
Yeah.
So I think that was the last question. I wanted to thank everybody for coming. I'm really hoping that there'll be more of these about workplace violence. As a case management study, New England Public Policy Group, it's definitely one of the areas we're going to be continuing to look at and work on for the next year. So as we get new and more information, we'll be sure to share it with you.
Absolutely.
Thank-
And encourage everyone to continue the conversation.
All right, Amy, thank you very much. I appreciate you helping me tonight. Thanks, Maureen.
Thank you both, Amy and Jenny, for this wonderful presentation.